Welcome to the AUA News Inside Track podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
I'm Dr. Andrew Harris, chair of the American Urological Association's Quality Improvement and Patient Safety Committee. This is part 3 of 4 of our QI Project Guide podcast series. We've talked in episodes 1 and 2 about laying the groundwork for a QI project. Today, we're shifting into doing and studying what happens when you actually test a change in a real-world setting. I'm here today with Dr. Justin Ziemba, an associate professor at the University of Pennsylvania and one of the authors of the QI Project Guide. Thanks for being with us today.
Thanks, Dr. Harris, for having me and for the AUA and inviting us to discuss this new project guide.
And we appreciate the opportunity to discuss with you today and are very appreciative of all the work that you've done to help get this guide in its current shape. So we've introduced the Plan, Do, Study, Act cycles in prior podcasts. And when we talk about the PDSA cycle, we often talk about small tests of change. So what is a small test of change and why is it important to start there?
Great question, Andrew. So a small test of change is just a limited scope pilot that kind of gets your project off the ground in the implementation phase. You really want to see if the ideas and the plan that you've come up with are going to be capable of being implemented without sort of probably devoting all the resources, all the time that you may need for the full project into this limited scope. So a great example is for us, we're embarking on a project to get ureteral stent to ureteroscopy time shortened between that patient who shows up with the obstructing ureteral stone gets stented and gets their definitive surgery. And so as we conceptualize this project, a small test of change might be how do we look at this process over a 2-week period, let's say, where we may have 1 or 2 cases come through during that time frame to see if our processes in place are functioning without fully rolling it out.
Yeah, I appreciate that. Sometimes I think you don't know what you don't know, right? And so when you run a small test of change, you might figure some things out that, oh, we didn't think about that. And it's a lot easier to make that change on your next cycle in a small venue than if you say you do this all over the city in which you work, right? Or all the different hospitals in which you work. So appreciate that thought. So how long do you run this first test? How do you decide that?
Yeah, so great question. I think it depends on the specific, project and the specific area you're trying to improve on. So you got to think about how much time it takes for that event to occur. So if something only happens once every month, you're going to need a small test of change that may be 1 or 2 months. But if you have something that's taking place multiple times a week, you may only need 2 or 3 weeks to be able to do that small test of change and get some data to be able to see, are we making improvements? And is our process working before we roll this out completely? So for our ureteral stent example, that's something that happens pretty frequently during a week. So we may only need 2 to 3 weeks to see are the processes in place that are working before we make a bigger change. I think the last piece that's probably important is how critical the project is that you're working on. So if you have a very high acuity, high risk project, that has potential patient harm, that may be something that you need to run very quickly versus something that may have more of a large process improvement footprint, or is for overall learning and organizational growth that may take place over a longer period of time.
Yeah, that makes sense. So you really have to have enough time so that you could have enough data, and also that whatever change you are making has time to manifest in the process that you're watching. So that makes a lot of sense. So when we get to the point of implementing an intervention, the QI Project Guide outlines 4 steps: finalizing a plan, carrying out the intervention, collecting the data, and then auditing the intervention. So before jumping into testing a change, what does a strong implementation plan need to include?
So I think, early in the planning phase, you got to have a process map and you got to have an understanding of what the current process is, what your idealized process is going to ultimately look like, and then kind of where you're at and, what the practical piece of that process is at this moment in time. So you really need to think about clear roles and responsibilities, who's going to be in charge of the process, who's required to have what information, who acts at different parts of the process. You also need to outline all those steps for each one of those roles so they understand what the changes are that they need to make. I think understanding how people communicate and who they're responsible to, or who they might supervise, or who they might communicate issues or problems, also needs to be clearly established. You need to think about the resources that are involved. And then, of course, what happens when something may not go right? Who do you talk to? How do you fix it? Do you have the authority? Do you have to talk to someone else? And then what data points are you going to look at? I think all those need to be incorporated as you're planning, and certainly as you're implementing the plan, you need to have a rubric to make sure you're hitting all those criteria.
So along those lines, when teams put their change into action and they've tried to think about several of those items of which you just spoke, what do you often see they might forget, leave out, or not think about when they go down this road?
I think contingency planning, thinking about what you do when the process breaks down before it's even started, perhaps. Maybe you have a clear charge of what you as the individual, let's say in our ureteral stent example, conceptualizing this, we might have a scheduler that's in charge of coordinating this shortening time span from ureteroscopy to definitive surgery. What happens when that person is on vacation, or maybe they take a medical leave, or that person is overworked for the given day, and that day happens to have a whole bunch of ureteral stents that get put in overnight or during that day? Who's going to be responsible for that? And having those contingency plans in place, I think, are really important. And that kind of dovetails nicely into the communication protocols. I don't think we always fully detail who's responsible to who and how you communicate things back and forth.
I appreciate those thoughts. And it's such a great real world example. I was recently reading about a quality improvement project where a new process was put on a piece of paper, and this was used in the clinic, and it worked great until they ran out of paper and nobody put the next set, and then it fell apart. So like thinking about, well, what happens when the scheduler is on vacation, or if they have a sick day and those days? That's just such a great example. And really how some of these projects that are very well thought out go sideways very quickly. So important to think about just those basic maintenance of the project ideas that you just brought about. So I really appreciate those points. And I guess another question, how have you seen creative ways to integrate data collection into normal workflow? Because, people are like, I don't want to do something extra. How can we just do it in the environment in which we're already working?
Yeah, I think that's always actually probably one of the more challenging aspects of any QI project. We live most of our lives in EMRs and electronic systems, but gathering that data and making it usable for QI or research purposes is challenging, because those systems are really designed for clinical work and not always designed for data capture and data analysis, particularly for QI. So I think whenever you can leverage those processes that already exist, that's always beneficial. Automate whenever possible and make it purposeful for staff. So for instance, in the surgery coordinator example with the ureteral stent, our surgery schedulers are already scheduling surgery. They already have processes in place to receive messages from our nurse practitioners, from us as the clinicians on scheduling surgery. Now we just have to make them aware that they may be getting messages from other providers at some of our other hospitals, and they have a plan in place on how to intervene on those and schedule those surgeries. So leveraging that process and then taking that data that they already collect about how long it takes them to schedule, those can all be run automatically, because that's already part of the data collection for operative quality metrics. So using that information is very helpful. If we had to build that system on paper, have them jot down times and durations, that would be not really feasible.
So it really seems like what you're describing is a way to leverage a lot of the data collection systems that are already in place.
Exactly, whenever possible. Of course, there's going to be times where you may have to develop a QR code with a survey or a red cap or something of that nature to gather additional data that may not be available in the EMR or part of, routine processes. But certainly whenever you can leave that to the side, you're going to probably get more robust data by leveraging current practices already in data streams.
Yeah, it's a phenomenal example of successful quality improvement. You got to make it as easy as possible and make it easy to do the right thing, easy to measure. So I really appreciate those points.
Exactly.
Question for you. What should you be looking for when you're observing a new process in action? You've done all this work, you're putting it together, You're watching to see now in your example how these stents are getting scheduled for definitive surgery. So what are you looking for in that situation?
I think we have certainly two things that I would say if we're looking at the ureteral stent example, that I'm going to think about early on. As one is, what is the fidelity of the process? So are we actually doing what we intended to do in terms of the process itself? So are patients who are getting ureteral stents getting counseled on surgery? That information is getting documented. That's going to the surgery scheduler, and they're getting ultimately scheduled for surgery. And that time between stent and ultimate definitive surgery is shortening, but that process is actually happening. So we need to make sure that that's occurring. I would say the second piece is that we're actually starting to make some changes in that time frame and shortening that interval. So you can have certainly a high fidelity process, but that may not actually be making your change. So I think you need to look at both the process and the outcomes. And then specifically when looking at the outcomes, I think looking at outliers as well is also very helpful. So if you have a few outliers, the days are longer than they were at the start. Is there something else happening here that you didn't conceptualize or fully understand that should have been in the process but isn't? Or is there examples where the days were very short? Maybe there's a whole other piece here that actually can improve your overall process as well and make the time even shorter for everybody. So I think it's looking at the process as a standalone issue and then looking at the data, particularly those outliers early on.
Yeah, I appreciate those comments and really seeing if your hypothesis is correct, right? Does your process measure actually influence your outcome measure? Right? Because there are sometimes you're going to be like, our process measure is working great, but our outcome measure is not moving. And that's a signal to go back and take a look or take a look at those outliers and see what's happening. So really appreciate your thoughts there about how you start analyzing what's happening based on those measures. In the QI project guide, we talk about histograms, run charts, scatter charts as tools to study the intervention. What types of tools do you use in your practice to analyze and display data?
I think the run chart's just the easiest. Everyone understands those. They're easy to interpret. They're easy to create. They're easy to show. And it's very helpful to see the data visually. I think as you start getting into more complicated projects, you need certainly process controls. You may need to involve statisticians, but certainly plotting data over time is never going to be a problem. You can do that easily in multiple different, Excel type worksheets. So I think that's the easiest for the majority of the projects, at least to begin with.
So who do you share the information with and how frequently do you share it?
I think it depends on the project. So for instance, for our ureteral stent project that we've been using as an example, that's something that probably would be shared roughly every 4 to 6 weeks. Again, because these events are happening relatively frequently on a week-to-week basis. So we'll be able to start to accrue data very quickly and see the trend on a run chart relatively quickly and accurately over the course of only a few weeks. But I think as the early on in the project, you can probably never be hampered by giving data too much or visualization of that data too often to your project team, because that's the part where you're going to need to make the most changes. As the project matures, obviously, you probably need to look at that data less because the process has become just the way business is done. Hopefully, if your change is successful. And so I think early on, frequent data visualization, later on, probably not so much.
Yeah, I appreciate those thoughts. And especially at the beginning, when you're starting to see the data come in, it's a wonderful time to share because that's when people are motivated. They're in part of the process. They're saying, all right, hey, we're doing something different. Is it working? And really an opportunity to capitalize on that frontline stakeholder and team engagement to continue to make forward progress in the future. So appreciate those thoughts. So really want to thank everybody for being with us today and really thank Dr. Ziemba for his time and his expertise. So we appreciate you being here today and thank you for your comment.
Yeah, I really appreciate being here. Thank you, Dr. Harris and the AUA for allowing us to discuss this important work today for the project guide.
That wraps up the third episode in our 4-part series on the QI Project Guide. Today, we discussed implementing and studying the results of the QI Project. Be sure to tune in to the 4th and final episode where we will talk about acting on the results of and sustaining the changes of the QI intervention.
This has been an AUA News Inside Track podcast. Thanks for listening. For more episodes of this podcast, visit www.aua.org. www.auanet.org/podcast.